Support for this episode comes from Dexcom. Diabetes doesn't always have to interrupt your day. Dexcom G7, a continuous glucose monitoring system, sends your glucose numbers to your phone or receiver. Know where you are and where you're headed without finger sticks and without interruptions. Dexcom G7 is the most accurate CGM, and it's covered by Medicare. Learn more. Go to diabetes-connections.com and click on the Dexcom logo.
This is Diabetes Connections with Stacey Sims.
This week, if you're listening to this podcast, your glucose is probably front and center for you every single day, maybe every single hour. So why isn't blood glucose considered as and monitored as a vital sign? I'm talking to McElwee Malloy about this overlooked issue and her big plans to get it more attention. You may recognize Molly's name. She has worked at Tandem Diabetes for many years and kept us posted about Control-IQ and other advances. She's got a new job and this big new goal. As always with Molly, it's a great conversation. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of the show. I'm always so glad to have you here. You know that. I'm your host, Stacey Sims, and we aim to educate and inspire about diabetes with a focus on people who use insulin. I did something a little different this year and took some time away after the holidays. Just in terms of how our planning happened and best time to do things, I actually took a family vacation and back a couple of days ago. So we're hit the ground running. A couple of things I want to tell you about, before we dive into the episode proper. First is that Mom's Night Out Charlotte registration closes this Sunday, January 21st. This event for moms of kids with diabetes happens February 2nd and 3rd, but the registration is going to close this Sunday. Link in the show notes and always over at diabetes-connections.com. Click on the events tab to see all of our Mom's Night Out locations for 2024, and we're already working on next year as well. I also need a favor. I rarely ask for stuff like this because I'm not sure it even makes a difference for podcasts. I mean, I've been doing this a long time, more than 8 years now, but this is about reviews. Look, I love hearing from you all, and I do get emails almost every single day about the show, which is absolutely amazing. I got one from Jeff just a couple of days ago, who reached out after last week's Cernova episode, and he seems to have actually made it pretty far in their intake process already. Also heard from several new listeners. I think January is a time when a lot of people start listening. They're either new to this podcast or new to podcasting in general. So I'm super glad you found me, and thank you very much for the kind words. But guys, something weird is also happening. I'm getting a few 1-star reviews, especially on Spotify. It's very weird over there right now. I mean, no comments, just like a ring and run, with the worst thing you can do to a podcast, which is give it 1 star with no explanation or anything. So if you like the show, please take a minute to leave a review wherever you do listen. It doesn't have to be on Spotify. Of course, that would be great. But, you can write something. You can just click once to give us, I hope, 5 stars. It's really strange, though, because it's also happening on the new Type 2 podcast. I launched Diabetes Connections Type 2 back in November, and we've barely even really promoted that show yet. I'm starting to dig into that in this new year. But I hate to think that anybody would try to sync it before it really starts. I don't know if this is something nefarious or just somebody who listened to genuinely, a couple of people thought it stunk, so okay. But thank you in advance. I really appreciate your help on that. It's not easy to leave reviews. I think most podcast players and apps make it kind of tough. So thank you very much for trying. And I feel weird for even bringing it up. All right, my guest this week, as you heard, is the fabulous McElwee Malloy. She was a senior medical liaison with Tandem Diabetes. She has talked to us several times over the years about how taking part many years ago in the trials for automated insulin devices, she lives with type 1, led her to make it her career. But she has moved on now to something new with the goal of making glucose the next vital sign. McElwee Malloy right after this. Diabetes Connections is supported by Gvoke HypoPen, a ready-to-use rescue pen for treating very low blood sugar in people with diabetes ages 2 and above. If you take insulin or sulfonylureas, you are at risk for your blood sugar going too low. Low blood sugar emergencies can happen unexpectedly, and they demand quick action. You need a safety net when it matters most. Be ready to treat very low blood sugar with Gvoke HypoPen. Find out more, go to GvokeGlucagon.com/Stacey. That's GvokeGlucagon.com/STACEY. Gvoke shouldn't be used if you have a tumor in the gland on top of your kidneys called pheochromocytoma, or if you have a tumor in your pancreas called insulinoma. Visit gvokeglucagon.com/risk for safety information. Molly, welcome back. It is always great to talk to you. I am excited to learn what you are up to now. Thanks for being here.
Thanks for having me. I'm so excited to be back.
Oh, absolutely. The last couple of times you were here, listeners may know you best as the woman from Tandem who explained a lot of things, especially I was looking back at my notes in the other episodes, the run-up, the lead-up to Control-IQ, explaining a lot about how this came to be, explaining it when it was first launched. And frankly, Molly, I don't think I'm telling any secrets, getting into a little bit of trouble. Maybe you did because one of the things we love about you is because you were very outspoken. You were very willing to share a lot of behind the scenes information. So I really appreciate you sticking your neck out for us all those times. And I'm really excited to see what you're up to next. But I felt like we had to acknowledge that first.
Absolutely. And you know what? You know me, I like to talk. And I think knowing and understanding the foundation of the science that you're using or the technology that you're using is really essential. So I'm always a more is more on those kind of details kind of person. So I've had a long history with Control-IQ at University of Virginia, Center for Diabetes Technology at Type 0 Technologies, which is now a Dexcom company, and launching Control-IQ at Tandem Diabetes Care. So I've worked on automated insulin delivery for about 14 or so years. And that's been my life's work. And that has been so fun. And I have that has been just, I don't know, a gift to me to be able to do that and have that launched and have that in practice and have that in people's hands. And I have absolutely loved that. But I also have like a bucket list of items of other things I want to accomplish in diabetes. So that was the first one. And I kind of made a deal with myself. You have to cross something off the list before you can go to the next one. And it took me, 11 years to get Control-IQ on the market. I'm okay with marathons, right? So doesn't have to be a sprint.
So you're no longer at Tandem, which was not my fault.
And no, not your fault. Not at all. And not my fault either.
No, of course
right?
not. I'm teasing. Tandem's wonderful. Of course we use them. We love them. Make it a joke. But I know you're limited and we're going to talk big picture about what you're up to now. Can you share a little bit about the ideas that you're working on?
Yeah. So one of my next bucket list items is to make glucose the next vital sign, not just for patients with diabetes, for all patients. And that sort of ties into metabolic health, which we will get into in a bit. And the way that we do this is that it gets incorporated into the plan of care from the beginning, which is, as we all know, the electronic medical record, or you might call it electronic health record. So EMR or EHR, depending upon your verbiage, are all sort of run by these health systems. And they're all a little bit siloed in how they're working, right? So they're trying to do different things to try to accommodate different data and uploading PDFs. And there's all this information that's sort of going into the medical record, but it's not smart. I'm going to fix that. That's my next project. So I'll speak more about it as we get into it, but I am once and for all fixing this because it is a pain for patients. It is a pain for clinicians. It's a time suck to have to spend 20 minutes to obtain data to only upload a PDF, which is not then smart to be searchable, right? Or data that can be analyzed or gathered further in the medical record. This is just asinine that in 2023, this is how we're doing things. I found Locust, which actually happens to be Charlottesville, Virginia, where I am located. And they've done this with other technologies. And I pitched them doing it with diabetes. And they said, yeah. So that is my next project. And again, we'll talk more about it when I get a little less stealthy. But it's my next item here really is we need to have full vision, full ability to see everything that we're doing in diabetes. We have all of this incredible systems and data and stuff that we've done for the patients, but we've not done any accommodating to the healthcare professional to get it easy to use, easy to interpret into your electronic health record, which we have to use.
Let me ask you a question though about
fix that. Yeah.
So it makes perfect sense the way you explain it, right? The patient has all this information. I think about my son. He's got Dexcom integrated with his insulin pump with Tandem. So great information, lots of stuff to download. Ideally, what does it look like for the healthcare provider, right? In other words, they get this information into the medical records. How are they then using it? Because I think a lot of people with type 1 listening are like, I don't even need my doctor to see this. Like I'm on automatic. I've got this. So tell me why it's important practically, how would they use it?
So it's important in a lot of ways. So first, for the type 1 who is self-managing, right? You may not need your doctor have all of this, but what if you come in through the ER and then you're explaining your diabetes to someone and it's exhausting, right? I wear a pump. This is how a pump works. These are my settings. I wear a Dexcom. You don't need to stick my finger, right? This is the data. What if the data was there? They're like, oh, what's your glucose? Do they log in? They're like, oh, I see. You're doing fine at 145 right now. So I don't need to do anything with that. Oh, I see your insulin settings here. Are you using this pump still? This is what that looks like. The plan of care gets simplified, and any endocrinologist can kind of weigh in on a patient by just looking at the medical record, not having to go into this hunt and find. I go to the ER, I find the patient, I figure out what therapies they're on, I figure out the settings, I figure out what's going on, I try to put together some sort of plan of care. It's exhausting. It's not a good use of resources for them. It's really not excellent care for you or the patient. We could do this better, right? So if you're already the master of your disease, right? Like you have self-managed your diabetes and you're like, I don't need help. That is awesome. I totally applaud that. I think that is amazing. The people who take care of you do need help, whether you like it or not. And sometimes you have to have their help. I know the times that I have gone into the ER for whatever reason, I've just said a prayer to my husband, like, let's just hope that they don't screw this up with my diabetes. Like our goal here is to get out of here intact, no problems with diabetes, to address what other health issue is going on. And that's sort of just been my prayer as I enter. I don't think that is the way we should be operating anymore. It's ridiculous. And it's ridiculous for the healthcare professional to not have access to that wonderful, beautiful data set that can tell them so much, right? And what is this with finger sticks? Why are we still doing this today in 2023? We have CGMs. Why are we still finger sticking people and trying to figure this out? My analogy on using a CGM versus finger stick is that with finger sticks, you're driving in a car with no windows. You drive, right? You get out of the car, you see where you are. You're like, okay, I need to head that way. So you close the door, right? You have no vision. You go towards that direction and you can stop and get out and check where you are, right? That's a finger stick. Or you can wait until you hit something, right? A high blood sugar, a low blood sugar, get out, check, figure it out, fix it, reroute, and keep going. This is the dumbest way to manage diabetes ever. And when we have continuous glucose monitors, why would anybody use this? So I really want us to stop just running into things, right? You're just licking your finger and sticking it in the wind. That is what a glucose stick is doing versus CGM technology allows you to see around you. It's sensors, who's passing you, who's coming up behind you in the car. Is there something in front of you? How fast are you going? You don't know how fast you're going with a finger stick. You could be falling from the sky, but you don't know that because the finger stick won't tell you that. In this day and age and the data and the technology that we have, like it's just time to do better by our patients and our healthcare providers. And let's stop using antiquated technology. That's my rant.
I love that rant. That's perfect. I'm with you. Once you start with CGM, it's amazing. Finger stick was great for when it was better than peeing on a stick. But
yes,
let's
better
keep
than peeing
going.
on a stick.
But you're also really passionate about, and this sounds funny to say, but you are really passionate about metabolic health overall. Can you talk a little bit about what your hopes are for that? I mean, it sounds so broad, but let's just start there.
Right. And it sounds like a buzzy word, like when you hear people talking on the phone and they're dropping these like marketing terms that you're like, I don't know what they're talking about, metabolic health. But the reason it's so important, and I feel like patients with diabetes will get this at their heart of heart, is that if your glucose is not under control, you don't feel good. Yeah. Like, let's just be honest, you don't feel good. And not feeling good is a really crappy way to have to live your life. Also, not feeling good may be your baseline, right? Because your glucose has been elevated. And it's not just glucose, right? It's waist circumference. For women, it's being less than 35 inches and men less than 40 inches around. It's blood pressures, cholesterol, it's triglycerides. But all of this at the baseline, if BG is not, if glucose is not managed, right? None of these other things matter because you don't feel good. So getting all of these in perspective for everyone, not just people with diabetes, but everyone, kind of unlocks this ability to just feel better. And who the heck doesn't want to feel better? I know I love feeling better. And people that I've met that have had, extended diabetes for years, like type 2 for, I don't know, 4 or 5 years, and finally get diagnosed and finally get their glucose under control. They're like, I didn't realize how bad I felt. Right. And then the type 1s that are diagnosed, right. And then when they get on insulin, they're like, wow, I feel much better. As people with diabetes, we can identify that this is something that we should all learn and know about. So metabolic health at its core is glucose oriented, and CGM is going to be the next vital sign in my book. How are you doing with your glucose is how are you feeling? Mm-hmm. It's also really important for, the elite athlete and anybody doing kind of, relying on their body for performance, right? That's very, very important. Why don't we give normal people really good baseline health to work with before we ask them to diet and exercise and take these vitamins and do these rituals? I don't want to ask sick people to diet and exercise. I'm over that. It's dumb. It's offensive, right? Get people to health and then ask them to make lifestyle changes. You really can't make lifestyle changes when you feel like dirt. It's offensive.
Well, it's really interesting that you say that. So to be clear, you're saying that if your blood glucose is elevated, quite often, especially with type 2, the first thing the doctor will say is try diet and exercise. Or the first thing the individual will say is, I want to try diet and exercise. But mm-hmm. you're kind of looking at this differently, saying maybe medication or CGM first. Is that what you're saying?
Yeah. So first CGM, see where it's going, see how elevated it is. Maybe you don't know that you're rising to 300 after meals, right? Maybe you don't know that overnight you're hanging out at 220 and that's why you're waking up feeling so exhausted. So figure out where it is. Where is the car going? How fast is it going? GPS it, right? CGM is GPS. Where are we with metabolic health with this patient? Let's get them normalized. And that could be insulin, right? A lot of people with type 2 that go on insulin initially, then come off insulin and have sort of this regeneration of beta cell health afterwards. So, insulin's not the enemy, right? It's a medication. And it also should never be used as a threat. You're going to have to do this exercise or lose this weight, or you have to take insulin. Insulin's a medication for a replacement for something that your body needs. So we should not be threatening people with this. Use it, get people under control, whether it's with a GLP, GIP, and type 2 and SGLT2, or any of these medications to get someone to health first, and then start improving lifestyle. Because if you don't feel good, and I ask you to start getting up at 5 a.m. and exercising, you're going to hate me. And you're also not going to do it, right? Like, we know this. It doesn't work. It doesn't work. Get people to health, then get the changes in place, because you can maintain change if you feel good. And you know that is at the end of the light. That is what is happening. You are feeling good. You're not going down a dark tunnel. It's not forever. Give people the tools they need to do this.
And you mentioned a lot of terms there that I think people are more familiar with, but let's just be clear. We're talking about medications like, and I like to use brand names because I think people know them better, but you're talking about Ozempic, Mounjaro, Trulicity. Your list went by a little quickly. Just to confirm?
Yeah. Yes. So GLP or GIP hormone injection, right? So GLP, GIP is a dual agonist. That's the Mounjaro of the world. And then a GIP standalone would be like an Ozempic or a Wegovy. They're used in different ways for different people, largely based on insurance coverage, which is a shame because actually people respond very differently to these medications depending on who they are. I know for myself personally, Ozempic, I had this sort of irregular management of my glucose. It felt like the thermostat was on the fritz. Like sometimes it was uneven, right? And I was like, this is really weird. Like, I know my settings aren't changing every day. This is a very bizarre feeling. But then I went on Mounjaro and it was like steady Eddie, straight arrow, no problem. And that's not true for all people, right? So some people do really, really well on Ozempic. And then some people can't stand the side effects of Mounjaro. So being able to pick and choose what works best for the patient there is, I think it's key. And obviously there's an insurance hurdle there, which hopefully eventually goes away because the results are pretty miraculous. But that then helps kind of reset metabolism in a way. So decreases appetite, you feel fuller faster. It gets rid of the background hunger, which is associated with diabetes. I know we've all experienced this. I've talked to type 1s where we're finally taking medication now to help this, but we've been like, I've always been starving my whole life. Like I've been hungry. I need a snack every 2 hours. And it is a legit hunger. It's something you really can't ignore. But on my medication, I can. Actually, I feel hungry when I'm actually hungry, and I eat when I need to eat, and I don't overeat, which is important. But all of this to say that, there are medications to try, also SGLT2s, which would be for type 2. Again, not for type 1. There are some people who will use SGLT2s in type 1, but please just note that you need to work with your doctor on that because there is a risk of DKA, euglycemic DKA. So regular normal blood sugar and still having DKA. Just a note to listeners there to talk to your healthcare provider about that one. All of these things obviously need to be done in conjunction with your healthcare provider, but there are a lot of medications that can be started that help improve that little baseline glucose health.
Yeah. It's interesting, Molly, because you live with type 1 and yet you've taken Ozempic and now Mounjaro, which are not approved for people with type 1 diabetes yet. They can certainly be prescribed, but can you talk a little bit about that? I mean, you're somebody who you have great access, right? You have great education. You knew about these things, but can you talk a little bit about them for people with type 1? Right back to our conversation. But first, support for this episode comes from Omnipod 5. And I'm a big fan of choice when it comes to diabetes technology. I get so excited when there's something new because if you live with diabetes, you deserve to find the best fit for you. That's just one reason I'm working with Omnipod to help spread the word about makes it so easy to test their system out. If you want to try an insulin pump or see what life with tubes is all about, you can try Omnipod 5 with no commitment or obligation. You can try Omnipod even if your current tubed pump is in warranty. No, really, you heard that right. And if it's not right for you, no problem. Omnipod does not tie you down with a contract or a tube. Go to diabetes-connections.com and click on the Omnipod logo. For full safety risk information and free trial terms and conditions, also visit omnipod.com/diabetesconnections.
Yes, this is a really interesting one. And I just want to caution listeners that if you do want to go down this route, that you have an educator, you have an endocrinologist who will work with you to do it safely. So just full disclosure, that absolutely has to be lined up because it is not something you just try, right? Like this is a serious medication. Again, I am incredibly privileged to have access and be able to do these things. But the GLP-GIP that I am in love with is called Mounjaro. It's made by Lilly. And a very small dose of it for me works beautifully. But I also was on Victoza for 10 plus years, which is a GLP-1, right? So it's a single agonist, whereas Mounjaro is a GLP-GIP dual agonist. There's something about that for me and my body that was magical. So I now am at the weight that I was before I had diabetes. I was diagnosed as an adult, right? So I had a portion of my life where I didn't have diabetes. I never had a weight problem. I never overate. I didn't feel the need to. Once I got on insulin, it was very different. I struggled really hard with my weight. There was this sort of feeling of inflammation, puffiness when I looked in the mirror. Like, I'm like, I don't recognize this person. This really makes me sad. And so when this came on the market, I was like, I need to try this to see if this will help me because I've been struggling to lose weight for years. Worked with professional trainers. I've worked with dietitians. I've done meal planning. I've done everything you can imagine, including some of like the psychiatric meds that try to help you lose weight, which is honestly, as somebody with OCD, like it just can make you crazier. So full disclosure, like that's probably not a great way to go. But the GLP-GIP was magic for me. I was not hungry and it wasn't an easy thing to do. My insulin sensitivity jumped. It skyrocketed. I reduced my total daily dose by over 11 units overnight. So by that, I had to go to, I went to a 0.1 basal rate with control IQ and I let it modulate up. So basically I was like, okay, I know I need insulin. I need something. I'm going to let control IQ figure out what I need. I'm going to then take the total daily dose and I'm going to redo my setting. Again, privileged to know all this information, to have all this information, but cutting the basal way, way down and then being incredibly conservative with boluses for a week got me feeling good and confident and then got my total daily dose down, which is where the weight loss happens. So The problem in type 1 that we're seeing when people are trying these medications is that they're struggling with hypoglycemia. So they're eating to feed the medication, right? So the total daily dose doesn't actually go down because you're still consuming all this sugar to try to prevent the hypoglycemia. So you have to address it by cutting the insulin first so that you can then meet the needs of the body where it is, rather than having to overcompensate with feeding glucose all the time for low blood sugars. And that's something that lots of providers have told me, oh, well, I decrease it by 20%. And I'm like, you know what? That is not enough.
Really?
You need to go further than that. Go by 50%. Let them run high for one day, right? Figure it out and then reset. Automated insulin delivery can be beautiful for this, right? Because it can help make up where you need it. But just keeping in mind that sudden hypoglycemia is real and you may have to have glucagon on hand, right? And you inject it and you're in it for a week. So you're going to have to make accommodations with your insulin prior to starting. And you need to work with your doctor on this as to what it is for you. But I promise you, whatever anyone recommends, go down 10% more in what you need, and just to be safe, right? Because nobody wants to be low, particularly low for a week. That is miserable. I know I felt like I was pregnant again, right? Like when you're pregnant and they're like, stay at 60 for
Oh my
9
God.
months. And you're like, I hate this. This is not sustainable. And also I can't even carry a conversation with my glucose at 60 for 9 months. But that's what we ask pregnant people to do. Regardless, this is just something to do very carefully. But it allowed me to go back to the weight that my body wants to be at. And I feel really good metabolically. All my cholesterol, triglycerides, everything has improved dramatically. I don't have to be on statins for that, which is kind of, again, magical. Blood pressure is much lower. All of these things improve. So whole health improved with that drug.
One of the big things I hear from people, type 1, type 2, people who want to lose weight, I get a lot of questions about these medications, especially since we've done a couple episodes on them now. And the number one question is, what about side effects long term? And I know that they've been out for a lot longer than most of us realized, but I don't know. Do you think about that? Do you have any thoughts on that?
Yeah, I have probably more thoughts than we have time. The thing with this, and you have to be willing, there's a little give and take, right? I am taking a medication that hasn't been tested for, what does it look like 20 years later? I'm also on a medication that I will have to stay on in order to receive the benefits, right? This is not something you take, lose weight, and then get off of. It is a forever kind of deal. I've sort of just come to recognize that is the deal that I'm making, and it may also have side effects, and it may someday that I have to stop taking them, and then I'm going to be 25, 30 pounds heavier, maybe 40 pounds heavier than I am right now. And that is with the homeostasis I'm going to need to keep, because that's where I need to be. The side effects on nausea, vomiting, I have found that people who have been on GLP-1s before, like if you've never done a GLP-1, like start with a Victoza, start with an easy one, not a heavy hitter, get your body used to it so that you're not nauseous, so that when you start something mega like a Mounjaro or Wegovy or something like that, you're not setting your system up for failure. So take time to prep your system, get exposed to the medication so that you can kind of level out and see where you are, avoiding the nausea, etc. If you're taking these medications that's causing nausea and vomiting, you do not want to be taking these medications, right? You stop taking the medications. I read something in, I think it was like a Reader's Digest or something the other day where someone was like, oh, Ozempic ruined my life for 2 years because I was vomiting for 2 years. And I'm like, no, you chose to continue to take a medication and your doctor continued to prescribe a medication that was making you sick for 2 years. That's a very different story. So know that you may have to pull the plug and that is part of it. There may be long-term side effects. You certainly can't take this for your breastfeeding or planning to become pregnant or pregnant. Like those are things to consider. We don't know what the risks are on fetal development. And one of the things that we're very leery of, we don't know the long-term side effects, but the thing that I rationalize is that long-term side effects of having diabetes, right? Higher risk of cardiovascular disease, higher risk of peripheral vascular disease, macrovascular complications. So like retinopathy, right? Heart disease, kidney disease. I'm at risk for all of these. But if I get my metabolic health house in order, right? So my cholesterol is good, my triglycerides are good, my blood pressure is good, my waist circumference is good. I have a heck of a fighting chance against the rest of the things that are kind of already stacked against me. So for me, that trade-off is worth it, but everybody needs to make that decision for themselves and with your provider as to what's best for you. But it is a gamble. I'm not going to say it's not.
That's fair. These conversations are so interesting for the diabetes community as a whole, right? We aren't talking about just type 1. We aren't talking about just type 2. And that can be a tough conversation for some people to kind of, I don't want to say understand. That's not really fair. I don't know. I'll put it this way. When Benny was diagnosed, he was 2 years old. I was just learning about what type 1 diabetes meant. And I put this wall up, right? It is not type 2. He didn't do it to himself. He didn't eat too much sugar. He's just a baby. And as we got further into the community, really smart people like yourself started educating me on, while that language is understandable in the beginning, it's not really helpful. This is really one community. And I know I always get pushback whenever I said that, so that's fine. But this is another thing that you're really passionate about. Can you talk a little bit about that?
Yeah. So I would love to see this hashtag go viral, but T1 for T2. And the reason I want to see type 1 for type 2 is that in the type 1 community, and I get a lot of awesome opportunities to talk to R&D and other things in different companies. The thing about the type 1 community is we're too small, right? It's not enough bang for your buck to develop a new drug or to develop new insulins. Like we're a smaller community. But if we combine forces with the type 2 community, everybody wants to innovate for us. There's also tons of innovations in type 1 that really benefit the type 2 community. So automated insulin delivery is one of them, right? If you have type 2 diabetes, the way that we're treating it right now is we let you ride high for a very long time with your HbA1c and collect complications before starting insulin or any other medication. And then we ask you to stick your finger, which we've already talked about as antiquated. And then we ask you to do multiple daily injections. I'm just going to say that phooey on all of that. Nobody wants to do that. Put them on automated insulin delivery, get a baseline that works for them, right? Let it go up or down, let it modulate and see what you can get by without having to do meal bolusing even. So, and type 2. So it can be a real solution in the type 2 community that type 1s have, we worked really hard and advocated for. But sharing this with them makes it a bigger market, which means that people want to innovate for us, that people want to invest in future opportunities, that they want to make faster insulins because the money's there. We're a capitalist system, right? The money has to be there. The type 1 community is far too small to warrant a lot of the money spending innovations on like faster insulin, for instance. But you combine us as a community and we've got real power in the market. So I would love to see us type 1s advocate for type 2 diabetes, to involve them in our efforts, whether it's for coverage, medications or new technologies or what have you, or, just rights under the Disabilities Act, right? We need to come together because we need a bigger community in order for people to be even interested in investing in us. And also, nobody asked for type 2 diabetes. So let's just put that out there. There is this sort of stigma that gets assigned to people with type 2 diabetes is that they did it to themselves. And the fact of the matter is, no one says, I want type 2 diabetes. Nobody's ever said that. I want type 2 diabetes. Nobody wants that. So let's give them the tools that they need to get back to health, right? As we understand with type 1, get back to health, get glucose regulated so you feel better, so you can do more things. Like this is a solvable problem. We have the answers to this problem. We're just not using it right. So come together, advocate for each other. But we can do a lot for the type 2 community to help them feel better, to help them get solutions that work for them. And then we can get the reward of being able to use more solutions, right? Like the GLP, GIP-1 and get the indication, right? Because it would be worth it to do a trial with GLP, GIP-1 in type 1 diabetes with type 2 diabetes, right? While you have both going at the same time, if we were a market worth considering. There's a lot in it for us as type 1s to involve the type 2 community and vice versa to just, strengthen numbers. We're going to get the innovations. We're going to get advocacy. We're going to get coverage, reimbursement there'll be more of us. And we need to be able to get things like new medications covered for us, which you're right, GLPs, GIPs, not on label for type 1 diabetes. Why? No one's done a trial on it. Why? There's no money in it. So there's going to have to be a change where we look at these two disease states together, and neither one of these disease states should have any blame that goes with it, right? You can have type 2 diabetes and be a triathlete. You can be in amazing shape. There's a genetic component that is just not fightable at all times. You could do everything you can do, right, and still end up with type 2 diabetes. Also, you could be morbidly obese and eat McDonald's 3 times a day and not have type 2 diabetes because of genetics, right? It's kind of a wild card. And we all just kind of need to recognize the humanity of like, nobody's asking for this disease. There are 2 different types of it, but nobody deserves blame for having a disease. That's a ridiculous situation to put them in.
Before I let you go, I mentioned at the beginning that you and I have been talking for years. We started a long time ago. Your story is so interesting because, as I remember, you were in the early trials. You've mentioned type 0, for artificial pancreas stuff, and you really changed your whole career, your whole life to work on this. You've moved on. I know you can't tell us too much about what you're doing, and hopefully you can come back and share more about that in the future. But when you look back, I assume you feel like you made the right decision. Have things progressed to a point where you really feel like, wow, that was worth it? I did all this and, look where we are now.
Yeah. So one of the things that I experienced in this artificial pancreas trial is in 2006 was this just immense relief that the technology can reduce the burden of this disease. Some of your listeners also may identify, I've been very public with this. I have something called OCD. It's actually OCDP, which is personality disorder, or PD. Anyway, obsessive compulsive personality disorder. So I obsess about things a lot. So this can be diabetes, right? Checking my finger sticks 30 times a day is how it was manifesting in 2006. And then being really frustrated that those results were always different and sometimes wildly different. And I couldn't figure out the life of me where this is going. So participating in this trial and getting relief for the first time and seeing the brilliance of the engineers, of the endocrinologists, of the nurses involved, I wanted in. I was like, this is it. I will move heaven and earth to change my life around, to work on this, because it is that meaningful to me. And I have not had this feeling to date. That was huge for me. So I changed my life. I was a professional musician, which is a total different story. And I remember, telling my endocrinologist and the, engineer that I wanted to, I want to work on this with you. And they were like, so sweet. They're like, honey, we know it's really great. Thanks for volunteering to do this study. And I was like, no, I want to come work with you on this. And they were like, but honey, you play the flute. And I was like, I know it's not useful yet, but what could I go learn? Like, I can learn things. So they're like, go to nursing school. We could use a nurse who knows diabetes. And I was like, okay, like that's an easy thing to do. Wow, I was dumb. But anyway, hindsight, it was a great decision. It was still really, really hard. Nursing's really, really hard. But it was the right decision that got me into this. And nothing since then really hasn't been worth doing. Like, it's just all of it, whether it was, overnight studies in the hospital or, working 80 hours a week on this at a startup, whatever it was, that was all worth it to get to this point. And this point that I am now, I have the 30,000 foot view of diabetes and metabolic health and how this can change for everybody. And I want to do this next thing, which is get everyone feeling better. And making CGM the next vital sign is really my absolute goal in life. Next. So again, bucket list item number 2. First one took me 11 years to get to market. So I understand that this is a marathon, not a race. Hopefully this one's much faster. But yeah, it's been a crazy ride, but it's been totally worth it. 2000%, especially if it's helped anybody, right? I know it's helped me. This has helped me a lot, but if it's helped anybody, totally worth it.
It occurs to me, Molly, while we're talking today, a couple of quick things. You mentioned it was 2006 that you were in those trials. We are talking, you and I, on November 28th. This is I'll do the quick math. This is the 17th anniversary of not Benny's diagnosis, but of the first time we took him to the pediatrician and said, we think something's wrong. and they checked his blood glucose. It was a fasting, which was really fun with a 23-month-old fasting blood glucose.
Sure.
It was 80. But I had a really smart pediatrician who said, you know what? I don't like it. It's too classic. All the signs are type 1. Let's get a blood draw. And it took forever. It was 6 days later. It was a Monday and it was Saturday before we went to the hospital, but his A1C was 11.5. And so we had an earlier diagnosis than would have been because of my smart pediatrician. But I say all that to say, it's just incredible to think that in 2006, you were already starting the artificial pancreas trials. And here I am in 2006 with my baby thinking, what on earth is all of this stuff? I'm so excited Lantus has just been approved for toddlers. So we can do MDI and not NPH and regular.
Right.
Amazing stuff. It's just one of those weird coincidences. I didn't even think about the date. But yeah, this is not his diversary, but this is a significant one. So thanks for joining me. Keep us posted on what comes next. It is amazing to talk to you. And I can't thank you enough. Thanks for being here.
Thank you. And thanks to everybody for your support. It's been a fun ride. I can't wait to talk again.
You're listening to Diabetes Connections with Stacey Sims.
More information in the show notes, what she is able to share. As Molly said, she's a bit in stealth mode, but you can learn more in the show notes wherever you're listening or over at diabetes-connections.com. Click on the episode homepage. I also will link up our past episodes with Molly. She was an incredible source of information over the years about the evolution of Control-IQ. And after it was launched, more information about the real world use and applications of it. But we started talking to her back in 2016 when this was, Type 0 technologies, it was called. So if you're interested in that sort of thing, I'll link that up. You can go back and listen to some highlights from those past episodes. Before I let you go, a little bit of a report on Benny. He came home from college, like a lot of kids do, really run down. And he just spent a lot of time resting, obviously a lot of time with friends as well. It was great to have him home, but he asked if we could talk for the podcast when he's either home for spring break or maybe after the spring semester entirely, which of course it's fine with me. It's totally up to him these days. And we had an amazing vacation together. My family, the four of us, me and my husband Slade, my daughter Leah, and Benny, we spent a little bit more than a week in Costa Rica. It was just one of those dream come true vacations. It was to celebrate Slade and my 25th wedding anniversary, Benny's high school graduation, and Leah's college graduation. And it was phenomenal. Diabetes-wise, I'll give you the quick headlines from college because I know some of you have asked me how he's doing. The high-level answer is just fine. Okay. The more detailed answer is higher than I would like. He did see his endocrinologist over the break. And, Dr. Vanderwell is never going to lecture him, which is great. But he gave him a little bit of a chat about how things could improve. And also, I'm really grateful that Dr. V has always talked to him privately about drinking and partying and that sort of thing. I'm not in those conversations anymore, but I know that they take place. And I'm most comforted by knowing Benny is very open and explains diabetes to anybody that he needs to. I'm also really grateful for the perspective of so many of you, adults with type 1 and veteran parents, whose kids were diagnosed, before CGM, who've been a huge source of comfort for me and who point out, frankly, that what we consider high now was considered pretty average back in the day. And the day was not that long ago. I will say one more quick thing. It was much harder not to, I guess nag is the wrong word, but I'm going to use it anyway. It was much harder not to nag Benny about, did you bolus? Are you needing, insulin? It was really hard to do that while he was home, and especially while we were away together on vacation. Much easier when he's not in front of me. And we talked about that and we laughed about that, and he was really patient with me. And boy, I bit my tongue a million times. It's so hard when they come back and they're in front of you again. I thought he had gotten pretty good at that before he left for college, but I was not that great at it over the break. But I'm trying. He knows. All right. Have a pretty busy couple of weeks coming up. I have a busy year already in terms of travel and appearances. You can see all of that over at diabetes-connections.com and click on the community page. I'm going to a podcasting conference later this month. Then we have Mom's Night Out Charlotte, February 2nd. JDRF Type 1 Nation Summit in Boston. I'm keynoting that with Carrie Sparling, March 23rd. And then I'll be at Friends for Life Falls Church. That is April 5th. It's the entire weekend of April 5th, 6th, and 7th. That is very close to where Benny goes to college, so I'm getting a twofer. I'm going to go to the conference and see him and see if I can schlep him to the conference. We'll see. Lots more to come. Thank you, as always, to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I will see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.
As you are managing life with diabetes, Edgepark is here to support you on your health journey. Discover convenience and peace of mind with Edgepark, your trusted supplier in diabetes management supplies. Edgepark has a wide variety of pump and CGM solutions from top brands to fit your unique needs. Plus, Edgepark works with most insurance companies and handles the paperwork to navigate insurance complexities for you and make the ordering process as seamless as possible. You work hard to manage your diabetes. Let Edgepark take care of the rest. Go to diabetes-connections.com and click on the Edgepark logo to learn more.